Hello, thank you for tuning into this presentation. My name is Andrew Rogers. I'm a third-year medical student at Johns Hopkins. I began this research project last summer, working with professors across the medical school, public health school, and business school at Johns Hopkins. This project focused on the relationship between how hospitals spend their money and their performance on mortality and readmissions outcomes. The motivation for our study was to provide hospital CEOs and policymakers with information that could guide efforts to improve quality, particularly when resources are limited. While prior studies have focused on the relationship between overall hospital spending and quality, the relationship between spending on specific services and quality has received minimal attention. The literature thus provides executives limited guidance regarding how they should allocate scarce resources. This type of information is becoming increasingly important as United States payers move towards value-based reimbursement and away from fee-for-service. Our specific objectives were to examine the association between hospital spending at the department level and 6 clinical outcomes specifically for the Medicare population, which is the government-insured elderly population in the United States. These were 30-day mortality rates for heart failure, pneumonia, and acute myocardial infarction, and 30-day readmission rates for those same 3 conditions. We chose these specific outcomes because they impact hospital reimbursement from Medicare and thus are of high interest to hospital executives and policymakers. We had a couple key hypotheses. One was that the cost-quality associations would vary widely across departments, reflecting the differential value of different types of spending as well as differing degrees of utilization across hospitals. The second was that we expected spending related to discharge planning and transitional care services to be associated with lower readmission rates. Our methodology centered on a multivariable regression at the hospital level, with the hospital outcomes as our dependent variable and our independent variables consisting of both department-level costs and hospital characteristics. We had 19 different departmental cost variables, representing the average amount a hospital spent on a heart failure, AMI, or pneumonia patient. Examples of department expenditures we had included things like labs, radiology spending, spending on pharmacy, physical therapy, the emergency room, and so forth. Our data came from several different sources, shown in the second row. We obtained our outcomes from a national sample of Medicare certified hospitals from a publicly available database called CMS Hospital Compare. We derived our cost variables using 2 data sources. We used MedPAR to source department level charges, and then we obtained cost to charge ratios from the CMS hospital cost reports to convert these MedPAR charges to costs. Finally, we obtained hospital characteristics from the Medicare cost reports as well as census data. A few more additional comments on our variables shown in the last row. First, our outcomes were risk adjusted for patient age, sex, and over 20 categories of comorbidities. To risk adjust our costs, we divided costs by case mix indices and the Medicare wage index, an approach consistent with the healthcare finance literature. Finally, our hospital characteristics included other known confounders, including teaching status, location of the hospital, ownership of the hospital, area-level socioeconomic factors like median household income, and finally, the number of heart failure, pneumonia, and acute myocardial infarction patients treated at these hospitals, since there's a well-known volume-outcome relationship. So we ran our regressions, and we found the associations between our independent variables and the outcomes fell into 4 buckets. On the left, one group of costs did not have a statistically significant association with any outcome. Moving to the right, another group of costs only had negative associations with certain outcomes, meaning the more you spent, the lower your mortality or readmission rates, which is a good thing. A third group only had positive association with outcomes, and the fourth group had both positive and negative associations across different outcomes. For the purposes of this short presentation, I'd like to draw your attention to one variable, which was the spending on occupational therapy. I'm selecting occupational therapy because compared to the rest of our findings, our results for this variable was the most robust, and also we think the most actionable from the perspective of a hospital executive. To discuss our findings for occupational therapy in more detail, occupational therapy was the only cost variable negatively associated with all 3 of the readmissions variables. On the left, I display the magnitude and significance of the association between occupational therapy spending and outcomes. As you can see, our sample sizes range from about 1,600 to 2,800 hospitals. And we found that spending $100 on occupational therapy was associated with a 0.36% to 0.68% absolute reduction in the readmission rates across the three conditions we looked at. On the right side of the slide, I'm showing a distribution of how much hospitals spent on occupational therapy. The point here is the distribution of spending is A, quite variable, and B, a very significant proportion of hospitals spent none to very little amounts on occupational therapy. In fact, 75% of the patients in our sample received no occupational therapy. Taking a step back from the statistics, we think there is a plausible story for why occupational therapy spending might lower readmissions. From a qualitative standpoint, it's being increasingly recognized that elderly patients' functioning and ability to perform basic activities of daily living often decline after release from the hospital, contributing to readmissions. Occupational therapy is oriented around directly addressing these kinds of issues and does so in a very immediate fashion. Examples include training caregivers to ensure patients meet their basic functional and safety needs, performing home safety assessments, designing rehabilitation plans, and providing patients assistive devices like bedside commodes or performing home safety assessments to prevent falls. Occupational therapy can be a key component of discharge planning, which more generally in the literature has been shown to be an effective method of preventing readmissions. Empirically, occupational home therapy assessments have been shown to be effective in preventing falls within 30 days of hospital discharge, but to the best of our knowledge, there haven't been studies examining the direct association between occupational therapy interventions and 30-day readmissions. Based on our findings, we think this would be a worthwhile area of future study. And the fact that this hasn't been well studied and is not well understood suggests the possibility that occupational therapy may actually truly be underutilized. There are several limitations to our study. 1, our outcomes and costs are risk adjusted using different methods. 2, we used overall hospital cost to charge ratios rather than department specific cost to charge ratios, which may add noise to the data. 3, our findings are specific to heart failure, pneumonia, and AMI and may not be applicable to the rest of the patient population. In conclusion, we found the cost-quality relationship to vary greatly by type of spending. Our data suggests occupational therapy may be an underutilized discharge planning strategy to lower readmissions across a range of conditions. We acknowledge that this analysis is exploratory, and future studies are needed to establish a better understanding of the relationship between occupational therapy and readmissions. For example, similar analyses should be conducted at the patient level. The differential impact of specific types of occupational therapy services should be explored. And causality can be better assessed by studying outcomes at hospitals before and after the addition of occupational therapy services. Lastly, assuming the benefits of occupational therapy on readmissions withstand scrutiny, cost-effectiveness assessments of investing in occupational therapy will be needed to provide guidance for hospital quality improvement efforts. I'd like to acknowledge everyone listed on this slide for their invaluable guidance and encouragement while I worked on this project, and I want to thank you, the audience, for listening.